So Arabella, I'd love to hear from you about what your ideas are and what you think of when you think about trauma-informed care.
So trauma-informed care as a theory has been around for several decades now. Sandra Bloom, Roger Fallett, Maxine Harris, and many others, but specifically those three come to mind, brought trauma-informed to a level that at this point it's in everyone's lexicon. Does that mean that individuals understand it? By and large, some folks do, and others, when they think about trauma-informed, they think more about trauma awareness, which is to understand what trauma is, defining trauma, the symptoms of trauma. To be trauma-informed is more than that. Clearly, we need to be trauma-aware. To be trauma-informed requires that an organization recognize the impact that trauma has on everyone, not just the patient who's being served, but also on the employees in the organization. And when we understand the trauma, when we begin to think about the story, what's the story, as opposed to what is wrong with that person, we shift in the way that we approach individuals that we work with. And as we have that shift, we think a little further. So part of it's the story. The other part of it is recognizing what are the principles that support us in being able to create these healing environments, to be these listeners. So we look at the principles of safety. We look at the principle of choice, collaboration, empowerment, cultural competency, and trust. So as a provider, all of those terms are lovely terms that I hope that I embody. And to be able to do that at an organizational level as a leader requires you looking at your resources and figuring out how you want to be able to create a blueprint to make that change happen so that you can be mindful of all those principles and you can figure out how to embed them in policies and in practices, and how to surround yourself with a core team of individuals that can promote this work and focus on education and training so that everyone in an organization, not just those that come into contact with the patient, but other individuals, perhaps people in a record room or the maintenance staff, all receive education on the impact that trauma has on everyone.
When I think about some of the women that I worked with who were survivors of trauma, and I think about the level of trust that has to be built every time you meet with them. And I think about that idea that it could be very almost feel insulting to a practitioner who's known someone for a while when a patient walks in and they don't immediately trust them. And so I think that understanding that trust is going to have to be built in every time you interact with that patient. Otherwise, you lose the relationship. And I think when you have that ability to build trust, and you come from that perspective of knowing that the patient is not going to trust you automatically, that it's with that, if the whole team can do that in that trauma-informed process, it can lead to seamless care because the patient will trust everybody across the board. And if the patient trusts you and you trust this practitioner, the patient is much more likely to accept the warm handoff with somebody that you trust, and that it's clear that you trust them.
The trauma narrative, when I think about working with other providers, especially providers that perhaps haven't achieved that level of trauma-informed that, say, another organization has, and they're just on a different place in the continuum. One of the ways that I choose to look at it is to begin to ask, what's their story, as opposed to what's wrong with them. And all too often, when working in those interdisciplinary teams, there's this tendency, this default to blame the other. And to truly be trauma-informed requires that one sit as a provider and look across the table and begin to wonder, there's a story there. I may never know the entire story, I may not need to know the story, but understanding there may be a reason why that individual is working the way that they're working. And when we think about that scarcity model, if this is an agency who feels under siege and has limited resources, that provider sitting at the table is operating from that framework and likely is wanting to do either a flight or a fight or a freeze response. So to be trauma-informed is to recognize that everyone coming around the table has a different story that may not be the same as my story. And before I go to that stance of blaming the other, to really try to take a step back and begin to recognize the importance of collaborating by listening to each other and beginning to value the stories that everyone brings to the table.
The phrase that came to my mind as we were talking about this is something that comes from from a mental health perspective, but that idea of privileging the client's voice. That if we provide that ability for the client to have, or the patient to have, their voice privileged, as if they are the most important thing in this process. And I think that's true in organizations, that I think sometimes direct line workers don't feel like they're often being heard, and that there's no place where their voice is privileged, that they're often being told what to do, they're being reminded of the bottom line, and yet no one in the organization, or they don't feel like anyone in the organization listens much to what they have to say and what this process is like to be on the direct lines with folks. So again, back to that trauma-informed organization, I think trauma-informed organizations are those that can have that ability, can allow patients and staff to have their voices heard.
So have other doctors talked to you about the risks of weight?
Yeah. Yep, just about every time I go in, actually. I can accept myself for the way I am, and I don't understand how others can accept me for who I am. And, it's really none of their business, really. People seem to judge you and think they have the right to comment on your body just because of the size that you are, and they really don't have the right. People don't have that right.
So what hasn't worked in the past?
Everything.
And what has helped?
Nothing.
When Pat went to visit her DO, and her DO came in to sit with her and proceeded to ask her some questions, I was struck by Pat's response to the doctor. And as Pat was responding to the doctor, she was responding to a feeling of being historically shamed about her size, and having people make assumptions and be intrusive, and as she voiced those concerns, there was also anger in her voice as she was describing that. And as she was doing that, I was also struck by how resilient Pat is, because Pat was also able to say, I can accept myself, but you can't, others can't. So from that trauma triangle perspective, it's so tempting for a provider to look across the table and to view that individual as resistant or challenging or in denial, when in fact what's happening is that that patient is making her voice really clear and saying that that's not acceptable to me, that I accept myself and you don't. So as a provider, what role are we assuming there? Are we going to perpetrate? Are we going to continue to blame and shame her? Even on a micro level, not being consciously aware of it, because the trauma triangle is an unconscious interaction that's happening. So are we going to perpetrate? Are we going to rescue? Oh, poor Pat, I'll just do it for her. Are we going to be the victim? Oh, yet another challenging client that I have to meet with today. So I'm feeling victimized by my client. So as a provider, what is required of us is to pause and recognize and hear what Pat is saying, and then recognizing how that is sort of triggering our own sort of narrative and that of the organization, and then find a way to break that triangle and to respond in a more conscious way.
This is what I could find of Pat's medications.
Thanks, Mrs. Chalmers. I'll take an inventory, and then I'll send these over to the pharmacist for review. I understand Pat is waiting to get in to see someone.
Yep.
Okay, we should be able to help with that. We'll schedule an appointment for her with a doctor
Good.
before she leaves, and our internist will help with that transition.
Good.
Can you tell me, is there a family history of diabetes?
I thought she was here for a broken ankle. What's it got to do with it?
Well, I was just in with Pat and the physician assistant, and the physician assistant was asking Pat if there was a family history, and Pat seemed upset.
Family history of what?
A family history of diabetes. Pat said it was okay if I spoke with you about that. When she came in, we did a finger stick, which is what we do when somebody's about to go into surgery, and Pat's blood glucose levels were high. We've sent a sample off to the lab, and we're waiting for that to come back. We should know more soon.
Well, she knows enough about diabetes, that's for sure.
Can I ask you again about the family history of diabetes?
Why?
The conversation that the nurse was having with Pat's mom about diabetes and about whether there was a family history, I was thinking about, in a trauma-informed organization, after a conversation such as that, where it might be a difficult interaction, it might be a little uncomfortable, because I think, she's not used to being asked those questions, that for that particular nurse to go back and say, I had a difficult conversation with a patient's mom, and I was really trying to help her to be part of the patient's support team, but it didn't come off that well. And just wondering, what could I have done differently? So that there's that vulnerability for learning and for making it okay to either make some mistakes or to not get frustrated and just blame the patient for the problem. So I was thinking about that in terms of the trauma-informed organization and that kind of support. Because I also think in that, when there's a trauma-informed organization, that there's this recognition that as healthcare providers, we come in contact with people who have had some horrific experience. And so that whether we have our own trauma or not as providers, that when we're exposed to other people's trauma and we're open to it, that it does create some uncomfortableness for many people. It becomes part of what we carry with us. And so to be able to have a safe place to talk about that, about what's being, what you're carrying with you, and a place to be able to debrief with it and to be able to have that level of self-care, not to be just told, do your job. Because I do think that's a very different kind of organization.
Right. Trauma-informed organizations that set aside time for self-care are providing that opportunity for staff to feel safe. What I find that is helpful in keeping staff safe and focusing on self-care is the recognition that the work that's happening may activate us. We're hearing stories, we're being present to individuals that are struggling in a variety of ways, and being present to that time and time again begins to wear down our resources, which is why self-care is so important. And as I think about that, I also think about that parallel process and how that then plays out. So a staff person who's taking care of themselves and is aware of that activation that's happening in turn can provide better care. And when that's not happening, what does that care then look like?
One of the unique opportunities that our students at UANE have is that they have the opportunity to work with other students across health professions. And one of the things that we do on a semester basis is we do something called IPTE, the Interprofessional Team Immersion. And in that we often have up to 8 or 9 different health professions participating in teams, and then they have an opportunity to work together to develop some of the interprofessional education competencies, and then they take those into actual simulation with standardized patients. And one of the things that happened, I think the second time I served as a faculty member, was a medical student said that when he had the opportunity to work as part of this interprofessional team, that he really felt that he was much more confident going in and doing the patient care, that he didn't feel like he was alone or had to have all the answers because he had all of these other people around him who he knew were as concerned and as interested in the patient's well-being. And I just thought that that was, from a faculty and an education perspective, that's exactly what we want our students to get out of that piece, is that sense of we're not alone. And so I think that speaks to the collaboration and that vulnerability, because it does take some willingness to be vulnerable, to admit that you don't know everything and that you may not have all the answers for this particular patient.
It's an opportunity to create a blueprint and to make some decisions about resources and how to manage those resources wisely. So one of the ways to do that is to look at training and education. So are all staff being provided with opportunities to learn about the impact that trauma has, not only on the patient, but also on themselves? And when I think about staff, I'm thinking about everyone in the organization, not just those that are on the front line providing that clinical patient care. So thinking about training and education and ways to promote continuing education so that staff feel valued, that knowledge is important to the organization, that we know that the field is constantly developing, so we want to stay on top of that. So learning about that, and then looking at ways of engagement. So how are we engaging? What does the physical facility look like? Is it a warm and inviting facility? And that speaks to safety. So when we think about physical safety, it's not just as simple as, do we have doors that lock? And do we have a well-lit parking lot? It also speaks to the physical plant. Is it warm and inviting? Are there private rooms? Do staff and patients know how to exit a building safely if something were to happen? And if they feel safe there in that space, then we can begin to focus on the emotional safety, which is really about that engagement that we want to have, that we know that is so effective, so that our patients continue to come back and see us and feel that they can trust us because we're paying attention to their emotional safety and how we engage with them, thinking about that trauma story. Yeah.
In the best possible world, we're at least one organization that provides multi-levels of care for a patient, or if there are organizations that collaborate that are all trauma-informed and keep the patient at the center. The best possible outcome is that there are fewer medical errors, there are fewer people who get dropped and through the cracks, and that people come and get their health care and don't let it go because they're too afraid to come back and not be listened to. Kind of like Pat, when it was clear in the video that she'd heard a number of times people talk about her weight when that really wasn't what was of interest to her, and that was not her priority in being there.
Robert Anda, the co-principal investigator of the Adverse Childhood Experiences, spoke several years ago about trauma-informed practice and what would a trauma-informed community look like. And he coined this term, healing community. It would be a healing community. So at every level, we would, whether you are in a school, whether you are at a university setting, whether you work at a bank, if you are a healthcare professional in a hospital, that everyone would recognize and understand the impact that adverse experiences have on our health. So when we think about social determinants of health and we think about those adverse experiences that impact our health, having that knowledge, having that awareness, looking at prevention as well as treatment in that collaborative way results in a healthy community so that everyone is part of that medical neighborhood, not just those individuals providing the healthcare services. But when we think about the system of care, everyone who touches the life of that child or that adult we all become part of that healing community.